I'm presenting the topic, Principles of Microsurgery. I'll present it using this outline: introduction, indications, contraindications, general principles, then specific principles, monitoring complications, and then local and regional challenges with conclusion. Microvascular surgery refers to the surgical coaptation of blood vessels that are 1 millimeter in diameter under microscopic magnification. It falls under the broad term microsurgery, which is defined as any surgery that requires magnification beyond the human eyes. And then, depending on the structure involved, if it is blood vessel, it is called microvascular surgery. Could also be microneural, lymphatic, if it is the structure involved are lymphatic structures. Supermicrosurgery is surgery done on vessels between 0.3 to 0.8 millimeter, while nanomicrosurgery are on vessels less than 0.5 millimeters. Microvascular surgery in all has advanced the practice of plastic surgery, creating solutions for previously challenging problems. Formerly, the reconstructive ladder is what was proposed. With the advent of this, the reconstructive elevator is also something that can be used, where sometimes complex procedures such as the use of microvascular surgery may be chosen as the first best option for a patient. However, technical expertise is essential for success. Adequate patient evaluation and preparation will aid successful outcome. The history of microvascular surgery dates back to when surgeons attempted repairing vessels in their lab. In 1552, Parry proposed the first vascular repair. In 1902, Carrel invented the triangulation technique. Most of these surgeries they were doing was not so easy because of the materials they were using. In 1966, Bonnke was the first of all did a microvascular surgery, and then they were using instruments used by watchmakers and jewelers, as well as very thin sutures. The invention of the microscope earlier before then was what also helped him to achieve this. Sometimes Bonnke is referred in some books to as the founding father of microsurgery because of the various surgeries he had done. He experimented and tried out several implantation techniques in animals. He tried using other things. He failed until when he was able to, he eventually used the microscope. That was where he succeeded. So many advances have been made in the field of microsurgery. Recently, in 1980, perforator flaps were discovered, and then in 1989, Koshima and then Soda, they discovered and named the DIEP flap that is used for breast reconstruction. Most of the advancements in constructive surgery, as you see, also parallel advancement in devices. So as more equipment are coming, then the ability of the plastic surgeons to be able to do more complex surgeries also improve them over time. And there are some technical considerations we need to take note of. Following vessel injury, damage of the vessel will expose subendothelial collagen. Normally, if there's no injury, the platelets will just flow by. But whenever there's vessel injury, the platelets will be attracted to the subendothelial collagen, that by von Willebrand factor that is expressed by it. The platelet clump gather there and they try to form a plug to prevent further bleeding. They first of all form a temporary platelet plug. Subsequently, the coagulation cascade, a definitive fibrin to help to cover that. If the process goes on normally and there's no more intimal injury, in 3 to 5 days, these clots would go off. A new intima will be formed, and subsequently there will be epithelial regeneration. However, if there's more injury around there, this thrombosis, this plug can with the activated platelet can become so large that to occlude the vessel, and then thrombosis of the vessel will eventually lead to ischemia that may damage the vessel around there. Also, whenever there's thrombosis of the vessel, or even whenever a tissue is cut off in preparation for microvascular anastomosis, there'll be a period of ischemia that will occur on the tissue because of blood supply that does not go there, will eventually cause ischemia, which can lead to necrosis of the tissue. Different tissues have different tolerance to ischemia. For instance, the skin can withstand periods of ischemia for up to 24 hours, but the muscles, because of the high metabolic demand, can only withstand ischemia for 6 hours. Irreversible ischemia after 6 hours. The knowledge of this is important whenever we're doing the microvascular surgery. So because of this, that's the reason why most of the time the donor flap will wait to do it last after preparing the recipient site, so as to reduce the periods of ischemia, the duration of ischemia. What are the indications of microvascular surgery? There are 4 broad categories. It's either needed to cover exposed vital structures, either joint surfaces, tendon, vessels, bone, then needed of periosteum. Then this can range from defect either from the head and neck down to the toes. It may also be needed to restore shape. For instance, for breast reconstruction following mastectomy, it's also needed to restore function. For instance, functional muscle transfer on the face for individuals that have facial nerve injuries. Sometimes it's also needed for hand and digital implantation. It has been used to reconstruct composite defects. It has been used for transplantation also, to move and to implant amputated parts, as I've mentioned. The flap composition that is involved in microsurgery, sometimes it may just be a single tissue, for instance, a cutaneous flap, like a perforator flap. Other times, maybe a composite flap involved involving both skin, also facial, and even bone. The contraindication, there are a few absolute contraindications. Individuals that have severe critical illness such that they will not be able to withstand prolonged duration under anesthesia, ongoing sepsis, or uncontrolled coagulopathy. The relative contraindications are extreme of age. In children, because the procedure is difficult, while in the elderly, because of the fact that they may have other comorbidities. Then smoking is a relative contraindication. They are at high risk of having wound healing problems. Patients that have had preoperative radiation therapy also is, for surgeons, are supposed to be careful because the vessels may be friable, but it's a relative contraindication. Patients requiring microvascular surgery may present acutely in emergency. So when those ones come, they may need some resuscitation and stabilization before they go. Other times, they may be as elective, as we've mentioned, some of the indications for patients that have tumor. So it may be a planned surgery where the tumor, after the tumor has been removed, then the plastic surgeon would be needed to do a microvascular surgery to cover the resulting defect. Some patients may also come in after their digits have been cut off, so they may present as emergency. I put this slide to inform us about how they are supposed to preserve the tissue. Ideally, the patients are supposed to wrap the digits, for instance, whether a digit or limb, wrap it in a moist gauze, put it in a nylon bag, and put it in a slush of saline before bringing it to the hospital. That's to prevent the finger or the part of the body from coming into direct contact with the eyes to prevent injury to it. So what are the general principles to take note of when we want to do microvascular surgery? Patients should be selected carefully because it's a long surgery, and then it's also prone to complications. So we want to be careful so that we would get good outcome when we do this. Also important to develop a careful preoperative plan as well as a backup plan. Adequate technical setup, we'll see as we go. Use a well-defined workhorse flap, especially one that the surgeon is comfortable with. And then optimum donor site should be gotten. The optimum donor site is the one that will be able to cover the defect that we'll have, as well as minimizing complication, that is donor site complication. Then obtain consent, pay attention to intra-op details, employ meticulous microsurgical technique, and then be vigilant during postoperative care, as we'll see later. Then sometimes the plastic surgeon will need to coordinate with other teams. So it's important to coordinate well with other units during oncology cases or other cases as necessary. And the timing of reconstruction may be immediate, especially patients that come in with cut-off digits, because we want to try to beat up the warm ischemic time of that digit. Although if it is preserved in ice, it may prolong it. And then it may be early for traumatic cases also, and some cases, and then delayed. As you see, early it is when it's done in less than 72 hours. Studies have shown that when flap surgery is done less than 72 hours, the outcome is better than those that are done within 72 hours to less than 6 weeks. Thereafter, it's after 6 weeks, the outcome will be good again. Delayed sometimes in the setting of malignancy. So these are the different timings. What are the specific principles? I divided it into these 3 categories. Preoperatively, we want to obtain a history. What is the patient's current illness? As we do that, we also want to know how strong the patient will be and fit for the surgery. We want to know the medical or surgical history. Medical surgery history will also help us know the drugs the patient is, and then so that for those that are anticoagulants, we need to taper. and then previous history with anesthesia, then social history. Does the patient the social history will help us know whether the patient takes tobacco so that we can stop it before surgery if it is an elective surgery 4 weeks before surgery. The social history will also help us to know whether the patient has adequate social network for post-op care. We want to do a general physical examination. We examine the current defect in traumatic cases or anticipate the defect for patients that have tumors that will need to be removed. So we anticipate the defect. We also examine the possible donor sites. I already mentioned that we should have our definitive plan, and then we should have also other backup options. Examination particular to this, but we have to examine the patient as a whole to also check out whether the patient has other problems that may make the patient not fit for the surgery. Investigations, because it's a long surgery, there's going to be a lot of fluid shift, intra-op. We need to do full blood count, full blood count to know the patient's PCV. We also want to group and cross-match blood. Sometimes they lose blood and we need to transfuse. Do clotting profile to be sure that the patient does not have any coagulopathy so that we can correct. Serum electrolyte to check the renal status. ECG, especially for patients more than 40 years. And then for some elderly patients that have respiratory disorders, we may want to do a pulmonary function test. Imaging that is done, chest x-ray for patients more than 40 years. CT scan may be needed of the region, either just to easily analyze the defect and anticipate the problems you may encounter. Sometimes you may need a three-dimensional reconstruction, especially in the head and neck. CT angiography may also be done, may be needed, especially if we suspect the patient may have deformities of the vessel. It helps us identify zone of vessel injury, location of the recipient vessel, and then rule out the risk of possible peripheral arterial disease. We also want to, as part of the preoperative principle, we also want to optimize patient comorbidities. Anybody that is booked for an elective surgery and nutrition is not adequate, we want to optimize nutritional status. We want to stop medications that will affect wound healing, like steroids, and then appropriately bridge anticoagulants. Then stop smoking cessation, as we've already mentioned. Planning, we want to take note of our donor sites, mark it, as well as our recipient site. Sometimes we need to mark before the day of surgery. That's preoperatively, while other times we mark on table. Obtain a photograph, counsel the patient about the duration of the surgery, the donor site, the possible morbidities, and the risk of the complications that can occur from either thrombosis to even flap failure. The patient ought to know of all this, and the fact that the patient may need to be taken back to theatre again. We also want to check that the instrument and the microsurgery room are in good shape. And then for a surgeon can take the normal dose of coffee if he takes it. We've talked about the plan and alternate lifeboats. Then the choice of donor flap will depend on the size and location of the defect, the type of tissue required to be repaired. Is it a bone defect, muscle? So all those will determine the choice. If it is a bone defect, we have to take a bone flap, osseous flap or osteocutaneous flap, depending on what we have available. The length of the vascular pedicule also, as well as the availability of recipient vessels. So the flaps may be perforator flaps, pediculed or free, and then we have the free composite flaps. Intraoperatively, we want to discuss with the anesthetist as well as the nursing team. Tell them about the duration of the surgery. If we need to change position, sometimes the donor site and the recipient site are on different parts. We also inform them about this. The anesthetist should also know that should try to ensure that the blood pressure is optimum during the surgery. We don't want anything that will reduce blood flow, that will compromise vascularity of the flap. Avoid vasoconstrictive agents and also avoid hypothermia. We want to catheterize the patient because it's a long surgery and ensure that the patient is making adequate urine output. Pad patient adequately. Then DVT prophylaxis. Surgeon position, because it's usually a long surgery and it's something that the surgeon will be doing from time to time, as well as the microsurgeon. It is important that the surgeon is comfortable during surgery, because if not, the surgeon will have a risk of having cervical spondylosis and other problems over time. So this is how the surgeon is expected to sit. Patient surgeon is expected to sit straight, actually with the head straight, then the elbow flexed 90 degrees, resting on a table, Can also use towels to pad it well. The feet should be flat on the floor, hips, knees at also flex, and the elbows, as already mentioned, should be at right angle, and the back and neck should be straight. Short intervals of rest can be taken by the surgeon. They are helpful. Then the equipment, what equipment will we need for this procedure? Magnifying equipment, either a microscope or a loop. The microscope, there are different types of microscope available. Could be the one that is single, the head that is single for only the surgeon. But this one that is here, it has two eyepieces so that both the surgeon and the assistant can see. Also, there's also a video output signal. Other people in the operating room, they can follow the surgery from there. The scrub nurse, anesthetist, and even the other doctors can follow, can also be used for teaching. Some current microscope have capability to do fluorescence dye to be able to assess the patency of the anastomosis after surgery. So the operating microscope, most of them is about 25 times magnification, but those of them that are currently in use have a magnification of between 10 to 12.5 with a focal length of 200 to 250 millimeters. Then the loops, there are different types of loops available. They have different magnification. So a loop can also be used. The advantage of a loop is that it is portable. Although the microscope will give a better magnification, but the loop is portable. You can move from one place to the other with it. So different surgeons, sometimes they use 2.5 magnification for flap dissection. But when they want to do anastomosis, they use a loop of 4.5 times magnification for anastomosis, because you need more magnification. We mentioned that the vessels are small. These are some instruments that are used for microsurgery. The instruments are small and most of them are atraumatic so that it will not fracture the needle. Remember that we're working on tiny vessels, 1 millimeter. As labeled here, the first one is a vessel dilator. It has a fine tip so that it will not traumatize the endothelium of the vessel. Then the next one is the Dweller's forceps. The Dweller's forceps looks like a non-tooth forceps. The others are the micro scissors, could be straight or curved. They are usually spring loaded. Then we have the dissecting scissors also. The G, we have the Eckland clamp to help during anastomosis, vessel anastomosis. They could be double opposing or single. And then the micro needle holder. So this is a venous coupling device that can help to couple for venous anastomosis. It helps to shorten theater time. Other things that are needed as instruments are the microsuture, a background. The background could be a contrast background so that it will help easily identify the vessel. It could be red, blue, a contrast material. Then irrigation fluid, heparinase saline, lidocaine or papaverine. Other equipment are microscopic hemoclips. It helps to make the surgery fast since we are not tying with sutures. Then intraoperatively principle, as I continue, we want to clean and drape donor and recipient side. Sometimes we may want to do it one after the other depending on where the sites are. Then adequate exposure is important intra-op so that you'll be able to see the vessels well as the sites you're working on. And then it's good to work on the recipient side first so that prepare it first before going to harvest the donor flap to reduce the ischemic time. Sometimes we may need to resect tumor or debride, and then we want to check the vessels at the recipient site for any sign of trauma, especially patients that have had trauma before they came. These are the different signs in this image up. There are Cobweb sign, measles sign, thrombus sign. In trauma, it's important to go outside the zone of injury to do microvascular anastomosis so that there will be a high chance of success. This is a correct way of preparing a vessel. The adventitia should be dissected off 2 to 5 millimeter from the vessel end. And then any side branch that is near the tip should be cut off, or a hemoclip can be used to cut it off so that we don't want it to get into the anastomosis, and because it will cause thrombosis, and we don't want that, as we mentioned. Always keep the vessel moist and then avoid tension. We want a tension-free anastomosis. We want to gently handle this vessel so that there will be no intimal damage. So once we have prepared and freshened the ends like this, we'll flush within the vessel with heparin and now clamp. We'll now keep it. We'll go, when you are done with the recipient side, we'll go to the donor site, harvest, and also prepare the vessel in a similar fashion. At the end of preparation of the vessel, when it has been divided and the flap has been dissected off from its bed, you can flush the vessel also with cyanide saline. Remember that we'll harvest vein and then the artery. Sometimes we may take 2 veins to 1 artery. Then before anastomosis, you want to check that the vessel is patent. Before anastomosis, we want to check that the vessel is patent. So perform a spot test, release the clamp and check whether the blood is flowing or jetting out from the vessel. That will show us that the vessel is in good condition. Can use a vessel dilator to also gently dilate the vessel end. If we get blood coming out of the vessel this way, it's a normal spot test. If it is this other way that it is dripping, it's an abnormal spot test. We may need to give more heparin or even dilate the vessel and put lidocaine to help to dilate the vessel. Then, when both vessels are in good, when both vessels have been dissected off, after flushing, we ensure proper orientation, and then we'll go ahead and perform the anastomosis. The anastomosis, we want to ensure that the anastomosis is tensionless, not under tension. If there will be any tension, we use a vein graft, and then there are other techniques, vein or arterial graft. Vein graft, arterial graft, or synthetic materials can be used if there's a significant defect. The needle should enter the vessel 90 degrees. The needle should be held, the micro needle suture. The needle of the microsuture should be held by the needle holder, that's midway, and then it should enter the vessel perpendicular at 90 degree vessel wall, 90 degree under direct vision, and then full thickness. The full thickness of the vessel wall should be cut, not the adventitious, full defect. Avoid backwalling. Some authorities advise that we should start suturing from the most difficult part and come to the other side. Some sutures can be laid on both ends or both edges. They will serve as stay suture, and then they can help during the anastomosis. The knot should be squared, and the number of sutures should be just adequate. It should not be too crowded, and it should not be too few. Then there's what we call rescue stitch, which we can put after the anastomosis. After anastomosis, and then if there's bleeding from any other point, we can put a rescue stitch. The anastomosis could either be end to end or end to side. End to end anastomosis is done if for vessels of similar width, diameter, are the 3 ways that the anastomosis can technique in which the ways the anastomosis can be performed. We can use the halving technique or 0 to 180 degree technique, whereby 2 sutures are placed on each end of the suture to divide the vessel wall into 2. Another 2 sutures are also placed, one in front and one at the back, to further divide it, and then we'll now put sutures in between those 4 sutures. So that's the halving technique. The back wall up technique aids visualization of the lumen. This technique is that the back wall is first of all sutured before we proceed to the front, and then the triangulation technique, that's not commonly done again. It's end to side anastomosis, especially when the diameter of the vessel, the ratio is more than 1.5 to 1. So that's when we can use end to side anastomosis. This image shows the angle, the proper angle at which the smaller vessel should enter the larger vessel. The angle should be between 30 to 75, not 90. And then the width, the arteriotomy made on the vessel the diameter should be 2 times the size of the vessel. The suturing can either be via continuous or interrupted suturing. Arteriotomy, that's the process of making up the opening on the vessel wall, can be done either using a size 11 blade, can be tented and then cut with the micro scissors, or a vascular punch can be used. So these are the various anastomotic technique. That's the various ways we can use to put the vessel ends together, mostly for end to end. We already mentioned that for end to side, we can use continuous or interrupted. So these are the other techniques. We can use continuous suturing, interrupted suturing, locking continuous, continuous horizontal mattress suturing. So these are all the techniques. A meta-analysis on all these techniques show that there's no difference in the outcome or patency rate if any of this is used. So whenever there's a vessel size mismatch, what can we do? The one thing we can do is to dilate the vessel. But if it is more than 2:1, dilation will not work. Then end-to-side anastomosis, as we've already mentioned. Other ways is that we can spatulate. The first image by my left is talking about spatulation of fish mouthing, while the one on my right is the triangular wedge excision, where a triangular wedge is cut off, and then the triangular wedge cut off from the larger vessel. Then the end is now sutured to fit that of the smaller vessel. Interpositional vein graft, most of the time, is when there's a gap that will make you have tension in the anastomosis. If the vein is to be used to breach an arterial defect, it should be reversed because of the valves. But if it's going to be used for a vein to breach a vein gap, then it could be used the way it was harvested. After anastomosis, you want to release the clamp from the vein first before the artery to prevent mural thrombosis, because we'll now have inflow without outflow. And then we want to put topical lidocaine or pipervirin to reduce vasospasm. Watch for signs of patency. For in the artery, there will be pulsation distal to the site of the anastomosis, while the veins will see it to become engorged again. If there's no sign of patency, then we can perform this strip test. This strip test, as seen here, we use the Jeweller's forceps, go distal to the anastomosis, place the first one, and then use another Jeweller's forceps to milk the vessel from the first forceps distally, and thereafter we'll now remove the first forceps. If there's filling up, it means that the anastomosis is patent. Sometimes, if this is still not working, you just check for kinks, twist, any compression. If there's no return after 15 minutes unstable, you will need to take down the sutures and redo the anastomosis. For cases of reimplantation, order of repair is that we'll do the bone first if the patient comes in early. But if the patient comes in late and the ischemic time is almost over, we'll start with the vessels, the vein, the artery, the nerves, the tendon, and then finally the skin. Apply dressings, let them not be tight with a window. Then implantable Doppler device is something that can be used, especially in buried flaps. They implant it after just distal to the site of anastomosis? I have an image I will show us later that will help us to monitor the flap, and then put a drain, because we don't want anything hematoma to cause tension on the flap. Postoperatively, patients should be nursed in a ward where the nurses are familiar with monitoring the flap, free flap procedures, antibiotics, analgesics should be given to prevent pain that will cause vasoconstriction, adequate hydration. Some institutions hyperhydrate to prevent thrombosis. Ensure the body temperature is maintained from pre-op and from intra-op. I beg your pardon. Intra-op and intra-op. I forgot to mention that adequate temperature. We don't want hypothermia. And then ensure also post-op that there's no hypothermia, because it will cause thrombosis. Anticoagulants may be used. It's not compulsory, depending on the surgeon's preference. The limb should be immobilized, elevated to improve venous drainage, and then positioned in a way that there will be no pressure on the flap. Then how do we monitor a free flap after surgery? This image shows the different monitoring techniques. Could be clinical or the use of devices. Currently, the clinical examination and the use of Doppler ultrasound is the gold standard in free flap monitoring. The clinical parameters, because there are two things that can cause flap failure. Either there's a problem with the vein or there's a problem with the artery. There's venous congestion, occlusion causing congestion, or arterial occlusion preventing inflow of blood. So the clinical characteristics to check are color. The normal color will be pink. Then temperature, the turgor, capillary refill, bleeding from a cut end. Some people will say we should scratch. We should not use a needle to put in that may damage the perforator. The vessel may be damaged. So whenever there's a venous congestion, the flap will look blue, warm, swollen. There will be brisk, dark red blood when the flap is scratched or the end is cut. Then for arterial occlusion, it will be pale, cool, flaccid, and then there will be slow or no capillary refill. The normal capillary refill is 2 seconds. Then the Doppler signals, normally in venous congestion, it is continuous, while in arterial occlusion, it will be rhythmic. and pulsatile. So that's the clinical I mentioned. The other monitoring technique is the use of implantable Doppler devices, as I already mentioned. So that's the Doppler device there, placed after the arterial anastomosis and before the venous anastomosis. It is placed before insert. I already mentioned that it is useful in buried flaps. The problem with it though is that it has a high false positive rate and there's a high risk of kinking with it. The other technique is to measure the transcutaneous oxygen saturation. So usually intra-op, after the flap is placed, oxygenation of the tissue is measured and that is taken note of. Then post-operatively, when the flap is monitored, they check the oxygen saturation of the tissue. Usually if it is less than 40, it means that the flap is not well perfused. To use this, sometimes we may wait till 72 hours after, 48 72 hours after surgery before we check this. The complications of microvascular surgery are flap compromise, either venous or arterial thrombosis, congestion, fat necrosis, hematoma with pedicle compromise, infection, wound breakdown, then donor site morbidity or complications. The others are deep vein thrombosis or pulmonary embolism, and then there's a concept of the no reflow phenomenon whereby there's no flow despite the fact that the anastomosis is patent. Sometimes if the ischemic time is very long before the surgery is done, it can predispose the flap from having this. Usually there's swelling of the endothelium, platelet aggregation. It is something that is reversible if it is cut between 4 to 8 hours, but it is irreversible after 12 hours. And injection of intraarterial tissue plasminogen activator can help prove this condition if it is detected on time. The flap may be salvaged if there's a problem with the flap. Sometimes the problem with the flap may be sudden, a sudden vascular compromise. Maybe there's a kinking and the blood does not go there, or it can be developed slowly. If there's a sudden vascular compromise, after attempting on kinking and others, immediately the patient should be taken to theater for re-exploration. But if it's a slow compromise, there are some things we can do. Even you can also do that for the sudden before you go to theater. You want to reposition the patient to relieve pressure, if there's maybe pressure or compression of the pedicle. If there's any compressive dressing, remove it, release any tight suture, assess hydration. If after all this, the flap is still not okay, we'll go to theater to re-explore. I already mentioned that there are other microsurgery technique. Our topic is microvascular surgery. So microneural surgery, microlymphatic surgery, when we are working on either on the nerve or the lymphatics. For lymphatics, most of the time, super micro surgery is also done. It is available in the country. Some centers have their microsurgeons in the country in case there's any patient that needs it. In conclusion, microsurgery has improved the reconstructive options available to the plastic and reconstructive surgeon. It has also made easy the management of complex defects. It is, however, still an emerging field in our environment. Adequate knowledge of the principles of microvascular surgery will help to improve the outcome whenever this procedure is performed. These are my references. Thank you.
For patients that might be on DVT prophylaxis before the surgery and they will possibly have to have heparin during the surgery, do we still need to discontinue the DVT prophylaxis?
The DVT prophylaxis, what we do is that you want to take note of what the patient is on. And then for instance, agents like aspirin that work for 2 weeks. So you want to convert the long-acting ones to short-acting ones like heparin. Yeah, so that's what we do. So someone that is on aspirin, you stop it 2 weeks before surgery. If patient has DVT risk for any reason, we may now continue Clexane that we can stop 24 hours before surgery. Intra-op, even post-operatively though, we still we'll give them, depending on the surgeon's choice, they may need it.
Antithrombolytic agents such as aspirin or heparin that may be used post-op. I wanted to ask, how long would this patient be on this antithrombotic medication? Is there any role for immobilization post-op after surgery to ensure that there's no disruption? The patient may need to be immobilized, that with a fixator is plain.
The risk of thrombosis is highest in the first 24 hours. So most people that give at least 1 week, first week, most of the problem though is the first 24 hours to 72 hours. Some give it for 1 week or 2 weeks. We don't want kinking on the pedicle. In fact, we don't want movement to affect the pedicle. So we can immobilize using a POP. But some people don't even apply POP. They instruct the patient, those that will cooperate. But if you're afraid of a patient that may not cooperate, if it is a site that POP can be applied, we'll put POP. Positioning, if it's something on the back, the patient will have to lie in a prone position. The no referral phenomenon is one of the complications that can occur following anastomosis. But I mentioned that one of the pathology or pathophysiology of it is when there's intimal damage or there's prolonged ischemia of a flap before revascularization. So because following a period of ischemia, when the flap is perfused, some toxins will be released that will cause reperfusion injury. So response to inflammation is edema, and then response to inflammation is edema, and there will also be extravasation of fluids. So that would now initially what I saw is that initially after the anastomosis, the fluid will flow, the blood will flow, and then subsequently there will be no flow of blood because of those inflammation that is occurring around that site. So that's the no reflow phenomenon. Most of the time, to prevent this from even happening, we should try to minimize the duration of ischemia. We should perform the anastomosis as fast as we can. Another thing that can be done is to put that tissue plasminogen activator at that site. It may help.
Part of patient selection, you also select what is realistic, because the patient may come telling you what she or he wants to be done. So if it is not realistic, you may not want to take that patient. That's in addition to what you have talked about patient selection. You talked about ischemia. You know, there are two types of ischemia. So which one were you referring when you were coating skin 24 hours, muscle 6 hours? Mention the one you mean. Is it cold ischemic time?
It's
Is
warm.
it warm ischemic time? Especially as you're doing a free flap, so that people will get to understand. Immobilization, you say yes, you immobilize. Does it depend? I feel it depends on the site and even the type of free flap you've done. If it's not over a mobile area, your emphasis should be on positioning, instead of thinking of POP and all that, because it may affect your monitoring of the flap. But if it's across a mobile area, yes, that's when you emphasize on immobilization. As part of your principles, you mention positioning. That should be done even before surgery. Post-op position, you mention it intra-op. And even duration of surgery, you mention it intra-op. I feel that should be pre-op assessment, and even involving the anesthetist, the patient, how she or he will position herself after surgery, and then duration of surgery. The scrub nurses, the anesthetist should be aware, not just intra-op principle, that they are just coming and they are hearing that the surgery will last that long. Then there's something big you miss. You talked about assessment of your defect, very important. What about the recipient vessels? You didn't mention anything about that. It is good to assess your recipient vessels and even do a Doppler. Doppler came in your presentation when you were talking about monitoring. So you should have mentioned this during your principle pre-op. You assess your recipient vessels, are they there or not just intra-op, because it may surprise you. The vessel has necrosis and is now very short. You may even need to anastomose or put an intervening vein graft. So you need to know that before you get into the theater. You say if there are some branches of the vessels, you just cut them off. Should be transected and ligated. Let's learn to use the right words all the time. You can't just say you just cut them off and then throw them. Then the size of the sutures, if I didn't miss you, I'm not sure I heard the size of sutures you use in this kind of procedures. Usually 7/0 down to 12/0, depending on what you are doing. And the needle should be 3/8 of that curve. So it's very important that one is mentioned also. For the veins, you say you will know them if there's engorgement. Sometimes there might not be blood in that free flap. So as you release your clamp, there might not be any engorgement until when you release the arterial part before the venous end. You will now see that engorgement. So it's not all the time you may see engorgement to test if your venous anastomosis is patent or not. So you may wait to release the arterial one first before that. Who does the monitoring? You say it should be done in taken to the ward that the nurses know how to. Are they the ones that do the monitoring? What's the role of leeches in this, your surgery?
The doctors do the monitoring. For free flaps, the monitoring in the first 24 hours is intense. In fact, it's initially hourly in the first 24 hours, or sometimes I see hourly in the first 6 to 8 hours before we now start doing 4 hourly. But the first 24 hours hourly, and then subsequently 4 hourly, because most of the time the risk of thrombosis is highest in the first 24 hours after surgery. And the nurses also, it's also important the nurses know. Sometimes if the doctors are not there, if the nurses are aware of some problems, they can also draw the attention of the doctors. But the doctors are those in charge. The role of leeches are the leeches are important in flap salvage, especially when there's venous congestion. The leeches, the medicinal leeches, the Hirudo medicinalis, what they do is that as they feed on the flap, they create some pores. Apart from the fact that they ingest some of the blood, the pores that they create also make some of the blood to flow out. So that will help to relieve venous congestion. But it's just that those leeches, there's this organism, is it Aeromonas organism that is in their gut. So most of the time we have to give prophylactic antibiotics against that organism.
Microsurgery is not all about free flaps alone. The safer word to use is free tissue transfer. Don't forget you are doing microsurgery. If you are doing digital implantations, it's also a form of microsurgery. It's not flap surgery. If you are doing a total thumb transfer or transplant, it's microsurgery. It's not a flap surgery. So I notice you are just concentrating more on flap. It's not all about. A very important tool you left out is the Doppler. You should actually have a sterile Doppler scan, Doppler in theater. You may need it intermittently while trying to even trace your vessel intra-op. So always make sure you have it as a backup. Fine, you're supposed to map it out before you go in, but intra-op, things don't always go as straight as you think in surgery. You may need to use a Doppler again to map out things properly for you. So it's one of the things you left behind. What's the difference between super microsurgery and microsurgery?
Microsurgery is surgery that is done on vessels 1 millimeter. That vessels are 1 millimeter in size. So the super microsurgery is surgery that is done on vessel between about 0.5 millimeter in size. Sometimes I will say between 0.3 to 0.8 millimeters in size. And the nano microsurgery are for those less than 1 millimeter.
Okay, essentially 0.3 for super micro and nano micro 0.1. Essentially, that's the usual cutoff dimensions for the vessels. The leech I asked you about, apart from the pus they produce and suck blood, you call the name of the organism Hirudo medicinalis. Hirudin is a very powerful anticoagulant. So while they do that sucking, they release hirudin as well, which act as a local anticoagulant over the flap and also facilitate clots and free flow of blood within the flap.
I didn't hear very much about the pre-op consent. Counsel the patient, the relations, about the extent of the surgery, contraindications. What are the contraindications for microsurgery?
There are some that are relative, but the absolute contraindications are patients that have uncontrolled coagulopathy, patients that have severe illness such that they cannot stay for long period under anesthesia.
The procedure may be prolonged, so the nursing team may not be one. They may be in different sections. For instance, if you have two operating surgeons, maybe those harvesting and those anastomosing, you now have a different nursing team for each of these sets. So they have to prepare and they have to be aware of the procedure and the length. Anesthesia.
The backwalling means that when we are putting the suture, taking bites, for instance, when we are closing the anterior wall, we now mistakenly also take the posterior wall with it, occluding the lumen. So to avoid that, that's why it's important that as we put the suture, we are seeing where the needle, we look at the needle tip to see where it's going to and avoid taking the posterior wall in addition.